Today we have the great pleasure of hosting Professor Hannes Hagström, who is the liverman of the Karolinska University Hospital. He's a professor of the University of Stockholm. Is a senior consultant hepatologist at the unit of hepatology at Karolinska, and also adjunct professor. He's also adjunct editor of a very old and very renewed journal, which is a Journal of Internal Medicine, which is based at Karolinska. Actually, it was created there, and it's gained a lot of credibility in the international scene. Is member of the EASL task force for ACC screening, and he also member of NASH Global Council, and is part of editorial board of different very rewarding and very highly international peer-reviewed journal. Today, Hannes is going to address a very interesting and very real problem, which is estimating risk of cirrhosis in the general population. I think that this is very important because general population is the population each doctor is seeing almost every day. It's not filtered. It's the real world. So I'm very curious and very keen to give the podium to Hannes to present his lecture. We have to be quick on time because at 3 o'clock at the latest, Hannes has to go back to work and there are a lot of patients waiting for him. Thank you, Hannes.
Thank you so much for the kind words, Claudio, and thank you so much for you to listen in today. So this is going to be a little bit of a talk of how can we think when we want to try to estimate the risk of cirrhosis in the general population, and of course it's going to be a little bit background also on SLD with some personal reflections and so on, and very happy to have a discussion after the talk with you as well, because this is of course not an easy topic, and I think we're still trying to figure out should we do this, should we try to do this, where should we do it, and how should we do it. So let's go. So of course you all know about the new classification in steatotic liver disease, and I will primarily talk about SLD here. SLD is, as you all know as well, it's defined by having steatotic liver disease, meaning that you have to have steatosis on imaging or biopsy. And if you meet any of the cardiometabolic criteria and there are no other causes of steatosis, then you probably have SLD. So this is, of course, a very, very prevalent disease now, and this is why we're starting to talk about screening. So if you have a prevalence of obesity, it's roughly linear to the prevalence of SLD. This old study just shows this quite nicely, that if your prevalence of obesity is around 20%, like it is in Sweden, then the prevalence of SLD should be around 20% as well. And the latest meta-analysis, as you all know probably as well, estimates the prevalence of SLD now to be 38% in the general population, and of course even higher in patients with risk factors. So in the type 2 diabetes population, the prevalence of SLD is around 65%. The prevalence of MASH is also quite high, around 31% according to this meta-analysis, but we should also keep in mind that all the studies that have looked at NASH, or MASH as we say now, they are biased in the way that they have done a liver biopsy for some reason, and we don't go about doing liver biopsies in the general population. So all of these estimates are probably, an overestimation of the true prevalence of steatohepatitis in the general population. Nevertheless, of course, it's also extremely high in obesity. More than 75% we think have steatosis if you have obesity. But it is also a little bit dynamic. I just had one patient before starting this talk who had steatosis on FibroScan a couple of weeks ago when he was at the nurse. But now, after some lifestyle modification, lost around 2-3 kilograms, only like that, no longer steatosis, but still an elevated liver stiffness. So it's also dynamic, which we have to have in mind. We're trying to transition, in the hepatology field. I think at least a lot of people are thinking in this direction, that we're trying to transition from specialty where we only manage severe complications in our patients, HCC, decompensated liver disease, transplant evaluations, and so on, to more think on the lines of how can we prevent liver disease at an earlier time? How can we identify the patients that have no cirrhosis but are on the track to develop cirrhosis, and how can we treat them to reduce the risk that they will eventually not develop these feared complications? So a lot of people have been focused, of course, on genetic and rare causes. Hepatitis C and B have, of course, been very big topics, but it's really these type 2 diseases that are sort of affecting most patients, at least in the Western countries that we're practicing in, so alcohol and obesity. And what we all want to prevent is, of course, to see these patients coming in with ascites, variceal bleeding, big HCCs to our clinics. You all know these patients, you see them every day, right? And they have no idea that they had liver disease before they come into your clinic with big abdomen full of ascites and so on. So MASLD, this is a disease where you have steatosis in your liver cells. So these big white droplets are, of course, steatosis. You then develop MASH, which is signified by having both steatosis, ballooning, and some kind of lobular inflammation. This will then lead to an activation of your stellate cells in the liver that will start to produce fibrosis. And eventually the patient will probably end up with cirrhosis if this process is ongoing over time. The natural history of MASLD has been estimated to something like this. So if you're interested in the details, you're happy to read this review we published in Lancet Gastro last year. So we can estimate that, okay, there's a 38% prevalence of MASLD, but the rate of progression is highly variable, and you can also regress. So if you have already progressed to F3, you can still regress to F2. And also, if you even have cirrhosis, there's possibility of regression. But you can estimate that in the MASLD population, then around 3% will develop major adverse liver outcomes within 15 to 20 years. And if you take the cirrhotic population, you can see that, around 0.5 to 2.5% will develop hepatocellular carcinoma per year. And the rate of decompensation is also quite high, 9% per year, median time 5.6 years. I've been doing so much talking today. So anyway, you can use this information to know a little bit about the time to develop the cirrhosis or decompensation. So if you have patients where you estimate fibrosis to be little, F0 to F1, well, it will take the patients probably 30 years to develop decompensation. Whereas if you have F2 patients, around 19 years, and F3 patients, maybe 6 years to develop decompensation events or HCC. So this is quite valuable because it means that, well, if you find patients in the F0, F1 group and they're a bit older, they're very unlikely to live as long, so you need to think about decompensation. However, if you have younger patients, and it's still quite high risk that they might develop decompensation if they're 40, 45 or something like that, you can expect them to live longer. All the natural history studies shows this, that prognosis is dependent on stage of fibrosis. So if you look at liver biopsies, we stage liver biopsies as 1, 2, 3, or 4, and we term stage 3 and 4 as advanced fibrosis. So what we want to find is really the patients who have advanced fibrosis. Because again, all the natural history studies show that the more fibrosis you have in the liver, the higher is the rate of outcomes from these classical studies from Angelo and our study from Sweden, for instance. Here we have patients with different stages of fibrosis. We also have these controls from the general population. And this is a study which up to 40 years of follow-up. So we can see if we start at baseline and we follow patients over time, we can see when they are dying. And if you see this straight line, which are the sort of the matched controls, they have the same age, same sex as the patients with MASLD, we can see that patients with F0 to F1, they have a comparable survival to those of the general population. So you don't really have a big survival deficit in these patients. It's only when you start to develop fibrosis, stage 2, 3, or 4, definitely 4, that your prognosis starts to take a turn for the worse. So again, this is why we want to find these patients, whereas if you find F0 to F1 patients, well, they will probably die from something else. And this is a study where we looked at this. So in the same sort of population, a little bit expanded, published in Gut last year, we looked at what do really patients die from when they have steatotic liver disease. And here in the dark red, this is liver-related diseases. So even in the F4 group, were patients with cirrhosis, but not decompensated, of course, compensated cirrhosis. Well, here the majority start to die from liver disease, but still around 50% will die from other causes. And this is, of course, also in patients who have liver biopsy, so they have some sort of indication to do a liver biopsy. So they're also a little bit selected. But you can still see the pattern here, that it's mostly when you come up to F3 that you start to have a tangible risk to die from liver-related disease. And as I mentioned before, we can also use this information to say something about the time to development of cirrhosis or decompensation. In this mathematical model, we found that it takes you at least 20 years in stage fibrosis if you have F0 to F1. Whereas it will at least take you a couple of years if you have F3 to F4. And this is the sort of worst case scenario. So what is clinically meaningful in the general population and in risk groups? So we want to be able to appreciate the stage of fibrosis, which is then also determinant of the prognosis. And it's good here to notice that the diagnostic tools that we use to diagnose fibrosis, they are often also predictive because if you can predict how much fibrosis the patient has now, you can then by proxy also say something about the future because you find them already on the track to develop cirrhosis. So if we can stage the fibrosis, we can get important information on the time to development of cirrhosis, which will then also tell us, do we need to treat this patient? How intense do we need to treat this patient? And what's the need for monitoring? Can we tell them just that, well, you're very lucky, you only have steatosis, you have no fibrosis, you will very unlikely die from liver disease, you will very unlikely develop cirrhosis, you don't need to go to the hepatology clinic, we can just follow you in primary care, you do have an increased risk for diabetes and cardiovascular disease that we need to take care of. Whereas you have patients who are, well, you're almost on the verge of developing cirrhosis here, we really need to start to treat you now to develop, reduce the risk that you develop cirrhosis. And you definitely need to come back to the hepatology clinic. The problems are, of course, that it is pretty damn hard to stage fibrosis in the liver. And we have well-known issues with liver biopsy with sampling error. So if you do a liver biopsy in 2 places, as we will see later, you might get different results. It's also an invasive tool, so it's not super easy to repeat it, to do it, yearly biopsies. I don't think anybody does that in your patients. You have the risk for misclassification bias, whereas you see a biopsy, but it's not really representative of what's in there. And there's also this ordinal scale 0, 1, 2, 3, 4. So it has a sort of a low granularity. So it's difficult to see if a patient has improved or worsened if it's only stage 2, because you can, of course, have early stage 2 and late stage 2, but it's difficult to see this on a biopsy. So this is how it classically look. So, in stage 1 to 2, you start to have sinusoidal fibrosis, periportal fibrosis, and then you have bridging thin strands of fibrosis, and in cirrhosis you have thick septa like this. But it's very important to say that it's not always this clear. So usually you can have a biopsy which is not so big, it's a little thin, and the pathologists have a hard time interpreting it. Further arguments for this is this study from a couple of years ago where they took 9 of the sort of best pathologists in the world and gave them the same liver slides to look at and trying to look at ballooning. So this is not fibrosis, but ballooning, but it sort of tells the same story. And each color here represents a different pathologist where they think they see balloon hepatocytes. So you can just see here that it's not a very big overlay here, and you have one pathologist here in light blue who is very sort of optimistic about seeing balloon hepatocytes all over the place. So if you show a pathologist a slide, you might get different results if you ask them on different times or if you ask different people. So this was actually the only balloon hepatocyte that all 9 pathologists agreed on, meaning it's sort of the ultimate balloon hepatocyte. So if you see a hepatocyte that is looking like this, you can be pretty sure it's a balloon hepatocyte. What about fibrosis then? Well, this is another study also a couple of years ago. It should say 2005, not 2025. Well, anyway, it was a study where they looked at 2 biopsies done at the same time in the same patient. So you did 2 passes in the liver and you did the 2 different sections. And here you can see the first biopsy 1, 2, 3, 4, and the second biopsy 1, 2, 3, 4. And it's not always matching, right? So here you have a patient with a fibrosis stage 0, but then second biopsy you have 4 patients who seem to have F2 here. So not so uncommon. So that means if we do a liver biopsy, we see F2. Well, are you really sure it's F2 in this place, but can it be F3 somewhere else? So what does this mean? Well, it means first, of course, that it's difficult to interpret biopsies, but it also means that all the models that we have now done in the field, like FIB4, but also FibroScan, they are biased because they're based on liver biopsy, and liver biopsy is biased. So it's difficult to know if the model is working. It's also a problem, of course, because you need to take the patient in to do a biopsy, which is, if you have done a biopsy yourself, you know, it's a rather complicated procedure. The patient has to wait for 4 hours, at least in our institution, after the biopsy. You have to prepare them a little bit. It's, of course, can be painful in some patients, and it's expensive. A lot of staffing issues. So what does this tell us about the current situation? Well, the minority of our patients will develop major adverse liver outcomes. But those that do have very few symptoms before they develop the severe disease, and then they have a very, very poor prognosis. So we're really trying to find sort of the needle in the haystack here. So how can we then, if we want to talk about population screening, how can we determine the stage of fibrosis without the biopsy? Well, there are, of course, a lot of non-invasive tests, and this is a very hot topic, and I think it's rightfully so, because there's still a lot of work needs to be done here. So we have markers of fibrosis, and we have algorithms. We have indirect markers such as AST, ALT, and so on, and we have more direct markers. And we can combine these markers into algorithms like FIB4, but also ELF, which are probably the most popular ones right now. And of course, we also have elastography tools. That's, of course, FibroScan, we all know about that, but it's good to know that there are also options which might be cheaper to buy. And we also have MRE and MRE to look at fibrosis. So these are good to use, you know, if you can take blood tests, but these usually require the patient to be referred to a hepatology service or a radiology department to do these investigations. So we have availability and we have cost. So these are, of course, quite costly, and they're also not so much available. And if we want to talk about population screening, I think it's difficult to argue that we should do MRE and MRE in our patients, because I don't think it's going to be possible to do this on a sort of a broader scale. So we also know that these non-invasive ways to measure fibrosis are actually, if we look at it from a prognostic pattern, they're usually quite as good as biopsy to determine who will develop liver-related outcomes later on in life. So this study from Lancet Gastro a couple of years ago showed that the AUC for biopsy to try to predict who will develop liver-related outcomes, it's around here 0.7 to 0.8 over time. It's the same for FibroScan, the same actually for FIB4, but it's not very good. So for this kind of test, you don't really want this poor predictive performance. So what does this AUC really mean? Well, it sort of tells you that if you look at patients who have developed liver-related outcomes and compare them to patients who have not developed liver-related outcomes, they're like 70 to 80% more probable to have a high FIB4 or high FibroScan value compared to those that don't. So that's maybe not super good. So what about clinical trials? I want to mention this as well because it's of course a quite hot topic currently. So the only approved drug so far is resmetirom. It's not approved in the EU, so we don't have it available here, but it's certainly available in the US, and we think it's going to be available maybe this year, but maybe more likely next year in the EU as well. So this is a thyroid hormone receptor beta agonist, meaning it will sort of boost the metabolism within the liver, and it reduces liver fat dramatically with a lower inflammation and also leading to fibrosis regression with benefits on the lipid profile. And the main results were published in New England last year, showing that you can get a NASH resolution about 30% compared to 10% in placebo, and also some effect on fibrosis, 26% versus 14% in placebo over this trial. Fortunately, here you also see that these patients have a reduction in LDL cholesterol, which is of course beneficial for this population. Yeah, and as we mentioned, FDA approval last year. But I think what's interesting to discuss here a little bit is also the FDA didn't require us to do a biopsy in these patients. So how can we use non-invasive tests to identify these patients? And also, how will we be able to know if a drug works? So I think those are open topics, so open questions. So let's go back to the topic a little. So we have our patients. They are usually in primary care. And what do we want in primary care? So if you want to risk stratify our patients in primary care, I think what we need is simple and cheap tests to rule out advanced fibrosis. And I do think these probably need to be blood-based because it's going to be difficult in a primary care setting to argue that we should do elastography. Whereas if we have patients who are referred to secondary or tertiary care, I think we can argue that we will want to have tests that have higher sensitivity and specificity. And if it's going to be a blood-based test, it has to probably outperform or complement radiology or biopsy, because that's going to be available in this setting. So what can we use? What about ALT? How good is ALT to identify fibrosis? Well, it's not really good. It has an AUC around 0.5, meaning it's like tossing a coin. But this is still one of the most common way, at least we in Sweden get referrals, because it's so tricky to educate our colleagues out in primary care. So we usually get referrals for patients with an elevated ALT. So this is pretty poor. We cannot use ALT to identify fibrosis specifically. What about all these simple blood fibrosis tests? Well, of course, we have the FIB4 calculator. And this is, if you don't know it, this is a blood-based test that was originally designed to look at fibrosis in patients with HIV and hepatitis C infection, and compared to biopsy. So this, of course, uses two cutoffs. You have the lower cutoff and you have the higher cutoff. And the lower cutoff has a pretty high negative predictive value, so you can be pretty sure that if your patient is below this cutoff, then it's likely that they don't have fibrosis. Whereas if you have patients above the 2.67 cutoff, you can be pretty sure that they have some advanced fibrosis, although it's certainly not 100%. I will need to refill this soon. Anyway, for instance, we have developed this in Sweden. This is maybe not so relevant for you guys to listen to, but it's also, we use different cutoffs and different units of measurements in Sweden. So we had to adopt this to a different calculator. We've also integrated this into our electronic healthcare chart. I'm not sure if you have done it in your institutions in Italy, but this has simplified things quite a lot. So now we can just order the FIB4 score, and it will automatically give us the AST, ALT, and platelets. For instance, in this patient, he had a very, very high score, which is, of course, a result that they have very low platelets at 29. So you have to also consider the parts of the FIB4 score. Of course, we have transient elastography as the next test, and you all know about this. I guess you have it in your institutions. I'm not going to spend too much time talking about this. But it's, of course, a nice point of care method that you, in a quick way, can develop, can use to see if the patient has some fibrosis. And the cutoffs are as this. So you have also again here, we like this dual cutoffs in hepatology, where you have a lower cutoff with a very high sensitivity to rule out fibrosis. And you have an upper cutoff with a high specificity to rule it in. But I think we can think about this a little like this as well. So we have a general population who are sort of at risk from SLD. And then you have those in the population that have known MASLD. And then, of course, you have the patients who have been referred to secondary care with MASLD. And again, I think we can think in terms of availability and cost. So if we want to screen this population for cirrhosis, we need to have tests that are available. And then if we have patients to this right end of the spectrum, we can afford to have tests that are a little bit costly and a little bit more advanced. But so how can we improve on this? I mentioned before that most of the tests that we have available today are based on biopsy. Biopsy is imperfect. So what is better than biopsy? Well, the best way, I think, is that we start to build models, prediction models, not diagnostic models, that uses hard outcomes instead of biopsy. Because hard outcomes, such as major adverse liver outcomes, are very unlikely to be misclassified. You know, it's hard to not capture patients who have ascites or liver cancer or bleeding esophageal varices. You will probably pick up most of the patients that develop these complications, and it's hard to misclassify it as something else. And I think we also need to think about, when we develop new models, that we need to do that in the target population. So primary care is quite different than specialized hepatology care. And this is probably why FIB4 has some flaws, because it was developed in such a specific population. It's actually very interesting to see that it performs as good as it does. And I think we also need to increase the knowledge a little bit of where should we look? Should we look in the general population, or are there specific risk groups that we should look more closely into? Being in the Nordic countries is probably a good thing if you want to do this, because we have quite a big potential for doing long-term follow-up studies, and much is centered around what we call the personal identification number. So this will be a little bit of an insight into how we do with research here. So we have something called the personal ID number, and this is this little number that all patients or sort of all citizens in Sweden are given. So in this case, this will tell you when the person is born. This is just an example, saying this person was born in 1966, February 2nd, and then you have a 4-digit number that sort of you can use to be completely unique. So everybody have their unique number. And this doesn't change over time, and you have it when you're born, and it doesn't change. And we use this number in all sort of aspects of daily care, when we interact with the government, with the private sector, banks, and healthcare. So if you go to healthcare, the first thing they will ask you is your ID, and then you will know your personal ID number, and this is coupled to your medical chart, and everything goes in the same place. And we can use this also to link this to different healthcare registers that we have in the Nordic countries. So for instance, this personal identity number is used to inform a lot of different registers. So for instance, we have cancer registers, so all cancers are in specific registers. We have patient registers. So for instance, every time a patient is hospitalized for something, they end up in this register termed with administrative coding. So it's possible to find everybody with a specific disease, say SLD, and then see, okay, who have then later developed cancer. There's causes of death register, birth registers, and a lot of different registers. And with some creativity, you can then use this number to link all of these things together to get a lot of data. So I will mention a few studies that we have done to advance knowledge on risk prediction. First, I want to mention this study where we looked at the specific Swedish diabetes register. So this is a register where most patients with type 2 diabetes are recorded, and it's digitalized, so it's run by primary care and so on. So every time you see a patient with type 2 diabetes at yearly visits, you have to enter their data into the system, and it's also automated, so it can extract quite a lot of data automatically from charts. This is just showing that in patients with type 2 diabetes, the more severe their metabolic syndrome is, the higher is the risk to develop liver disease. So if we compare patients who have diabetes and 5 different metabolic syndrome traits, they can see that they have a much higher rate of liver disease compared to patients who sort of only have been type 2 diabetes. But it's still not super common. So you can see here the cumulative incidence is around 3% after 15 years in these patients who have all 5 metabolic traits. We also went further to look at, okay, what kind of diseases infers the highest risk. So here you have a sort of a table with these states. You have obesity, hypertension, albuminuria, high triglycerides, low HDL. And you can see which are the combinations that carries the highest risk. And I think in this particular study, just to sum it up, we saw that actually that hypertension seemed to be a key identifier of major adverse liver outcomes in patients with type 2 diabetes. And we're now studying why is this. My suspicion is that this is probably at least partly caused by alcohol. Patients with diabetes, of course, also drink alcohol, and alcohol can lead to hypertension. Next, I want to talk a little bit, how can we risk stratify our patients without lab data? And this is not a study from us, but from a colleague, Fredrik Åberg in Finland, where they did something called the CLIV-D score. Not sure if you have read about it. It was out in Journal of Hepatology a couple of years ago. So this is a non-invasive model that tries to estimate the risk of cirrhosis after up to 15 years. And I think what's nice, it doesn't require you to have any lab data. So it uses age, sex, alcohol, waist-hip ratio, presence of diabetes, and smoking. So these are simple risk factors. You don't need any labs. And I think the beauty of this is that you can get some initial risk stratification before the physician visit. So theoretically, you can ask your nurses to do this, and you will end up with a risk score. Now we'll just zoom in on it a little bit here. So for instance, here you have patients who are men and they're age 70 years old. So you can stratify it here on no diabetes, non-smoker, smoker, and then your waist-hip ratio. So for instance, you can see that there are quite different risks here for a patient who is, for instance, a man, who doesn't have diabetes, who doesn't smoke, but is 70 years old. Well, if they have an alcohol intake of around 0, and a waist-hip ratio which is not very high, then the risk of liver disease, liver cirrhosis within 15 years is pretty much minimal. But if you have a very high alcohol intake, 49 units per week, which is of course quite a lot, and a high waist-hip ratio, then suddenly your risk is 20%, which is quite high. So this can be used to, as I said, risk stratify patients before they even take labs. So how can we do it with lab data? So We have all the guidelines that recommend screening in primary care using FIB4 to guide who should be referred to hepatology or to do a FibroScan. And I guess you all know these algorithms. They look kind of the same, with calculation of FIB4 as the first step in this these respective algorithms. And FIB4 is of course a good score, but it's been developed to rule out advanced fibrosis in already sick patients undergoing biopsy. So could there be better alternatives for primary care that are still simple and possible, also feasible to implement? And this is why we were interested in this, and this is unpublished data. We hope to get it out hopefully soon. It's been under review for quite some time now, but it's called the Cirrhosis Outcome Risk Estimator, or CORE. So it's a little bit of a copycat from the cardiology field, where they use SCORE. If you probably know about SCORE too for cardiology risk assessment. So here we use the Swedish cohort with this personal identification number availability based on more than 500,000 people that in the 80s and 90s gave lab measurements of common biomarkers, usually in occupational healthcare, which was popular at that time. And that means they also have a long follow-up, so median 27 years follow-up. And what we want to predict here is then not fibrosis on a biopsy, but rather cirrhosis and related complications based on these different registers. So this is different to the other scores that are out there currently used for this as well, such as liver risk or other scores that have used transient elastography or liver biopsy. During this time, we had 7,600 cases of cirrhosis, so quite a big statistical power to do calculations on. So what does this do? So this is a risk model that will tell you the 10-year risk to develop cirrhosis. And it's also a calculator that will tell you not only the high risk, low risk, it will actually give you percent. And I will not go into the statistics here, but I can tell you this guy is extremely smart and has done a lot of stuff, cool stuff here. But essentially, this is a pretty simple model. So it uses age, sex, AST, ALT, and gamma GT. So it's a little bit like FIB4, but it doesn't use platelets. Instead, it uses gamma GT and sex. And we have compared this, of course, to FIB4. And essentially what it shows that, well, it's pretty much better than FIB4. So FIB4 is still pretty good in this population, or AUC of 0.81. But CORE is even better. So at all sort of risk thresholds, it's better than FIB4. And we look at something called AUC over time. We can see that it declines a little bit over time, but FIB4 does that as well. But it's better than FIB4 over the whole sort of period up to 10 years. We also validate this in two different cohorts, one big cohort in Finland called the FinRisk study, and also the UK Biobank with around 450,000 individuals. And we find similar risk estimates around, in these populations, around 0.4% will develop cirrhosis. And this is a little bit of a busy slide, but it just shows you that the discrimination for the CORE model is better than FIB4, also in these two different cohorts. So for instance, in the UK Biobank here in blue, we can see that the predictive performance of this model is still much better than FIB4, although it's a little bit poorer than in the derivation cohort, which is natural, because when you develop a model, it's always better in the population you develop it in. So it's important to also do this external validation. When we look at calibration, which is another metric that you should always also use, this is looking at if the predicted risks actually correspond to the observed risks. Then we can see that, yes, it seemed to do. So this is the predicted risk here on the x-axis and the observed risk at the y-axis. So you can see that this model is pretty well calibrated, especially in the UK Biobank. It might have a poorer calibration up to when you have these very high risks, but you see very, very few people will have a 20% estimation of risk. And this is available in a model. So you can, if you're interested, you can use it already now. It's core-model.com. So for instance, in this patient, you can simulate this patient. So a 59-year-old man with a gamma GT here in units per liter of 69, an AST of 100, and an ALT of 95. Well, you can actually estimate their risk to develop cirrhosis here at 8.3%. So this is different from FIB4 and so on, which will just tell you high and low and intermediate risk, whereas this model will actually give you a percent. So then the difficulty is, of course, to know when should I refer my patient to hepatology, and that kind of work is also ongoing. I will also mention, probably as the last example here, sort of another example of the complexity of the problem. So if we want to screen for liver disease, now I've showed you now a blood-based version that we're doing, but we were thinking, can we do elastography screening in specific populations? And this was sort of piggybacking on the idea that patients with type 2 diabetes is a risk factor, and they are sort of a risk group to develop fibrosis. They already undergo screening. So these patients, they already do retina screening. I'm not sure how it works in Italy, but at least in Sweden, this is highly centralized. So this was a prospective cross-sectional study, including patients with type 2 diabetes that underwent eye scanning to detect diabetic retinopathy at a place in Stockholm. And so what we did was that, so these patients were eligible, the patients coming to this clinic, they did VCTE by nurses. And the patients who had more than 8 kilopascal or an invalid measurement at the first exam were referred to our institution, where they did a second exam, blood samples and biobanking. And just to walk you through this rather busy slide, we can say we had around 1,300 eligible patients. Interestingly, around like 25% of these did not give consent. They didn't want to participate in the study. But around 75% of the patients wanted to participate. And out of these, we had to examine 143 again because of elevated liver tests. So the distribution looks a little bit like this. So around 5% have very high levels, above 12 kilopascal, around 11% is between 8 to 12. But when we do a second exam in these patients, when they are coming back to a hepatology specialist after around 2 to 4 weeks, we can see that there's quite a big spread. So actually, in 45% of our patients who had more than 8 kilopascal at the first visit, they then had a normal liver stiffness at the second visit. So in the end, only around 2% of these patients had an elevated liver stiffness, so above 12, so about 3% of the total population. Another example of the complexity of the problem is these are the EASL guidelines, and I'm sure you know about them. So what we have done in this study is to look at how is this going to be feasible if we look at patients with type 2 diabetes. So we can estimate that in Stockholm, there's around 140,000 patients with type 2 diabetes. And using a lab-based database that we have available, we can then say, well, okay, how many of these patients, if we would take liver tests on this, how many would actually fall into these different categories? So the guidelines tells us that if you're below 1.3, we can reassess you every 1 to 3 years. And it turns out around 69% of the patients will end up in this category. But around 21% will end up in the intermediate category, and around 10% will actually end up in the high category. And this becomes quite high numbers. So 14,000 patients, 29,000 patients. Okay, what about who will then go to VCTE and then need to have a referral after VCTE? It turns out, using data from the previously mentioned study, that this will be around 5,000 patients as well. So we will end up with around 18,700 annual referrals for FibroScan. I can tell you that in Stockholm, we are around 20 hepatologists working with hepatology. Of course, you can think about nurse-led clinics and so on, but I think this is just signaling that maybe this is not going to be feasible. If we want to do these guidelines in real life, probably we need to rethink them a little bit before we get completely run over by requests to do FibroScans. So we either need to rethink these guidelines a little bit or actually scale up. So this just shows you how much do we need to scale up. So to conclude this talk, I would say that while we are in the sort of process of transforming our specialty from managing complications to think more of prevention and screening. This is a common disease where few develop severe disease. Fibrosis is the main determinant of the outcomes, and biomarkers that are focused on detecting advanced fibrosis do so, and they're also prognostic. And I think we need to think about different sets of biomarkers depending on the contexts, where we need to have cheap and easy biomarkers in primary care to triage the patients for next test, and more advanced markers in secondary care. The current paradigm is, as you know, but this will have the risk of false positives. So I personally recommend that if you do a FibroScan and you are a little bit unsure, then do it again, because if you don't, you might end up in a situation where you have a false positive FibroScan, you start to treat the patient with resmetirom or another approved drug, and then you see the patient again after 1 year, you do a FibroScan, you say, oh, it's normal now, but you don't know, is this a drug effect or was the first FibroScan just false positive? But I do think a lot more work is needed to develop and validate better biomarkers, especially diagnostic, but also prognostic and treatment response biomarkers. So that was a big talk, and thank you so much for listening and staying on. And I just want to end by thanking all the people in my research group, which are the ones that really do the hard work here.
Oh, thank you very much, Hannes. It was a beautiful presentation, very exciting and very provocative. I like it.